if I was to share the general picture for malaria, you realize that Busoga is number 2 in terms of burden for malaria in the Malaria Indicator Survey 2019. Following Karamoja that had 34, meaning that every time you met 100 people in the population, 34 would have malaria parasites. I think Busoga had 22%, meaning that every other time you meet 100 people in Busoga region, 22 would be carrying malaria parasites. And probably to explain the picture you're going to see in malaria in pregnancy. This is going to be my presentation outline. I'm going to speak to the background introduction, recommended reduction strategic actions, and the performance framework for malaria in pregnancy, that is 2021 and 2025. I hope members you're able to hear me. Am I audible?
Yes, we can hear you.
Yes,
so your voice is a little low, but we are hearing.
Oh, I'm going to also share the updated standard guidelines for malaria in pregnancy. These were first reviewed in 2011. That is why for some of you who could have heard about IPTP before 2011, you could have heard about the 2 doses as. Come again? Hello?
Someone
you could have heard about the at least 2 doses, but now we're speaking about at least 3 doses. That was a change that happened in 2011. Then you could have heard around 2014, between 2011 and 2014, the treatment for severe malaria in pregnancy never, especially in the first trimester, never included injectable tissunet, but from 2014, you realized that injectable tissunet was a recommended treatment. Then from around 2018 to date, although this has not formally communicated, but I think of 2 weeks ago, as of 2 weeks ago, we got formal communication from WHO that you can now use you can now be able to use ACTs, that is artemisinin-based combination treatments for treatment of uncomplicated malaria in pregnancy. I'll also take you through the performance, give you progress updates on the performance for the different indicators of malaria in pregnancy. I'll also tell you some of the general gaps and challenges that we are facing, and then some of the proposed solutions. Elizabeth, my slides are stuck. I don't know if you can move them. Just take me to the next slide. Trying here, but it looks like it's okay. I just wanted us to understand, just understand the background, why malaria in pregnancy is prioritized. It's still a public health burden, and it significantly contributes to maternal and perinatal morbidity, disability, and deaths. Some of the commonly encountered morbidities that are related to malaria in pregnancy include maternal anemia, but also congenital anemia, increased risk for PPH, that is postpartum hemorrhage, because you know once a mother is anemic, they will definitely turn out as PPH, preterm labor, fetal wastage through abortions and stillbirths, intrauterine growth restriction, prematurity, and low birth weight. As of the data we had in 2020, that is the WHO report, out of the 33 million pregnancies in the sub-Saharan Africa, 11.6, that's about 34% were exposed to malaria infections in 2020. The prevalence of malaria in pregnancy in Eastern Southern Africa is about 22%, although it's the lowest as compared to Western Central Africa regions, it is still a significant figure. Because when you look at our counterparts, they have about 39.8% and 39.4% respectively. Globally, malaria in pregnancy contributes to about 10,000 maternal deaths and 100,000 newborn deaths annually. That was in the year 2017. 11% of these were all from the sub-Saharan Africa, including Uganda. The 20% of the stillbirths were also from sub-Saharan Africa. And out of the total stillbirths registered in the sub-Saharan Africa, 872, that is 11%. That is in the year 2018, were due to malaria in pregnancy. So we can significantly note this, and we can see that if we do not effectively control malaria in pregnancy, this is how we contribute to maternal and perinatal morbidity and disability in deaths. In 2020-2021, Uganda registered about 16.5% of the malaria in pregnancy cases. And that is also, it registered about 0.5 to 0.3 to 0.5 severe malaria in pregnancy cases. This looks like a simple thing, but you'll see that ideally for you to be safe, you want to have about 0.1 or less, and then 0.5 malaria in pregnancy deaths were registered. It has also been documented that children whose mothers suffered malaria in pregnancy tend to have cognitive challenges as children and as adults. They'll have issues with judgment, they'll have issues with reasoning, they'll have reasons with decision making. And remember, as you're working so hard to attain a middle income status, and even better than that, you need a new generation that can reason and judge and make proper decisions for you as a country. So if we continue to have a high burden for malaria in pregnancy, what that means is that we're likely to have a cohort of children in the future that will definitely will be judging poorly and reasoning poorly, and probably coming up with very, very irrelevant decisions and insignificant decisions that will not propel the country forward. Next slide. Next slide, Liz, kindly. So as in order to mitigate all the above and the burden of malaria in pregnancy, WHO recommends a three-pronged approach for prevention and control. I kindly go back of malaria in pregnancy. Please kindly take me back. Kindly take me back to the previous slide. The first one is the intermittent preventive treatment of malaria in pregnancy. This intervention is involves you giving a mother who is pregnant sulfadoxine pyrimethamine. So far, it's still a drug of choice, although we are exploring other alternatives given the raising levels of resistance to and folate levels. We are trying to identify other molecules that can actually come in to replace SP. But for now, for intermittent, kindly, Elizabeth, let's share the right slide. This is, I've already spoken to this. Share the next slide, or yeah. So intermittent preventive treatment of malaria in pregnancy, commonly referred to as IPTP, with sulfadoxine pyrimethamine. Normally what is involved here is that you're giving this medication starting at exactly 13 weeks of gestation and giving it monthly until delivery. Please note that this is one of the changes that came into the malaria in pregnancy policy around 2011, because for some of you who remember, especially for the time we're in school, we are recommending that IPTP starts at 16 to 20 weeks, and that is when you would get the first dose, and then around 20, above 28 weeks, you'd get the second dose. That was the policy that changed, and the mother was safe with 2 doses of SP. And that time it was only mothers that were living with HIV that were not on cotrimoxazole that were taking more than 2 doses. But in 2011, this changed. I don't know what has happened to Elizabeth, because can I share from my side? Okay, I'm speaking to this slide. I hope everyone is able to see the slide. So in 2011, we are now, after studies, a number of studies that were done in Zambia, Malawi, where they realized that actually IPTP was effective when you gave a minimum of 3 doses, but you actually needed to give more doses. I think this was also premised against the fact that I think as the burden of ant-folate levels is increasing, and other resistance markers, I think we needed to give more frequent doses. So since then, the recommendation is that every mother starting at 13 weeks of gestation should start on sulfadoxine pyrimethamine and take it monthly until delivery. This was also based on the fact that the fear of excessive hemolysis that was likely to happen after 36 weeks and give you high concentrations of high concentrations of the byproducts of the hemoglobin breakdown and connecterus encephalopathy. I think there were studies that were done, and it was found out that actually even when you give SP after 36 weeks, you're not likely to have high concentration levels of bilirubin and end up with connecterus encephalopathy in the baby, because that was the feared thing for giving SP after 36 weeks of gestation, although this is continuously being studied to make sure it's actually a fact. For you to have impact on the burden of malaria in pregnancy, the coverage for mothers should be above 85%. But we're going to see where Uganda is, and then we think through what we are doing. Especially some of us here who are health workers, we're going to check and see if we are giving our mothers air, or if we are just clocking in and not putting in effort to be very sure that we try and reach over 85% of our mothers within our catchment area. As I present the performance data, you're going to see how we stand, and probably we're going to debate on how we can make this better. Then the number two intervention or strategic action is the distribution and use of the long-lasting insecticidal treated mosquito nets. Normally, the target for both ownership and use should be above 85%, and this should be sustained if we are to have transmission of malaria parasites reduced in the pregnant women. But just in case the mother gets sick, there should be prompt diagnosis and treatment with a recommended treatment. And here you'll see that in our current guidelines, and that is as of 2018, and since there was no committed intervention apart from the net, but also to avoid a situation whereby the mother is coming in for first ANC and you're giving them a net by when they are carrying malaria parasites and they're affecting them and their unborn baby, we now encourage that every mother that comes in, whether they are symptomatic or non-asymptomatic, because currently there are increasing levels of asymptomatic malaria to a tune of about 10 to 14% in the population. We encourage that every mother who comes in is actually tested. And you will note that one of the things we're working on, because we know that the easily used test is the RDT, but we are also having information that the RDT sensitivity, especially among pregnant women, is not the best. We're also trying to introduce highly sensitive RDTs to be used in antenatal. We're going to do a pilot, and then in case we pick very good results, it's something we're going to try and adapt and scale up. According to the Uganda Malaria Reduction and Elimination Strategic Plan of 2021-2025, for the section of malaria in pregnancy, these are some of the indicators we're trying to use to monitor performance. The first one is percentage of pregnant women attaining ANC that have malaria. The next one is percentage of pregnant women who have received at least 3 or more doses of IPTP, percentage of pregnant women attaining ANC. Please note that the first one is a coverage indicator, and it's usually picked during surveys. This third one is percentage of pregnant women attaining antenatal care who have received at least 3 doses of IPTP. This one normally, you'll note that we are looking at, it's an uptake indicator. We're looking at mothers who have sought ANC services and are given IPTP. Then the proportion of pregnant women sleeping under an insecticide treated mosquito net, because this is a standard. a mother who is using any other mosquito net is actually not using a standard net. We recommend, and actually we've gone an extra mile, and we are recommending long-lasting insecticide-treated mosquito nets, because there are other nets that need retreatment, and these are cumbersome. People miss out on retreatment, and they were not that effective. So we recommend that the standard should be using an LLIN. So we try and understand owning is one thing, but using is what gives you results. So the other that we try to look at, sorry, I'm not going to share updates on this. I don't know if you really wanted it. The percentage of facilities that are reporting more than 1 day of SP stock out in a month. Because you know, in as much as mothers will come, but you need to have the SP for them. Then the percentage of pregnant women attending antenatal care receiving LLIN, this points to ownership. And then malaria in pregnancy deaths per 100,000 is another that we look at. So please note that in as much as these targets are low, but we target that by 2025, we should be within the standard. We didn't want to be very ambitious, and that's why you're going to see that we put in the coverage we put at 80, and in the uptake we put at 85, because then you need to work hard to make sure your mothers are coming. So for now, for this year, okay, actually now the targets have even changed, because now we are into 2022-2023. For the malaria cases, really any region that has above 7 is performing very poorly. But previously, in the quarter that we have just ended, any region that had anything above 9%, and we're going to see how the different regions are faring. And then receiving coverage for IPTP, was supposed to do a malaria indicator survey this year, but because the UDHS is ongoing, we shall depend a lot on the UDHS results. UDHS was supposed to be done in 2021, but because of COVID, it has escalated into a different year, because ideally for us, we're supposed to be doing a malaria indicator survey, but we couldn't do both. Both of them are population surveys. And malaria indicator survey is a component. Most of the indicators actually picked under UDHS. So we thought that it was better for terms of managing resources well. We thought it was better for us to do the malaria indicator survey after 2 years after, probably. So our target for last year was 58. Now that is for the uptake, and now it is 67. In as much as we know that this is suboptimal, but we based ourselves on the performance then. We couldn't stretch so high because we knew that was not going to be possible. Then for mothers using nets, last year it was 75, now it's 80. And stock out, it was 4 and now it's 3. And then for mothers attending ANC that are receiving nets, it was 60, now it's 70. The acceptable level of malaria in pregnancy death was 7, now it's 6. And we're going to see how we are performing later. Sorry. Sorry, I'm going to talk to the performance later, because I just wanted to give you strategic direction at all. Before we go into details, let's try to speak to the guidelines. Remember the 3 interventions up here. We're going to see the guidance for all, and then we shall then see how we are performing in terms of indicators. For prevention of malaria in pregnancy, clearly we know we are using the insecticide-treated mosquito net. And please note that this schedule for IPTP is very, very well aligned to the new WHO antenatal care model, which I couldn't share here because I knew it was going to be a very long presentation, and I didn't want to lose your attention. But in case we want to get to learn or to get introduced to this model, I can talk to my colleagues to organize in case you're interested to come. And because for you to understand how we operate under malaria in pregnancy, you also need to understand to start with the ANC delivery model, both the previous one and the old one. So in 2016, WHO introduced a new antenatal care model that speaks to 8 contacts as opposed to the 4 antenatal care visits. Keywords in there are the number of, the change from the word, the paradigm shift from the word visit to contact. Contact is basically, if you can just put it together, it's respectful care. Does the mother feel like they've interacted with the health worker? Are they, other than as opposed to a visit where you come in and do your things, the mother is not aware, they don't see the benefits. So the key word to coin here is respectful care. So we shifted from visit to contact, and then also the numbers changed because we realized that we needed more contacts in the 3rd trimester, because that is when most of the complications occur, and we end up having very negative pregnancy outcomes and a very negative pregnancy experience. So also we aligned our IPTP schedule to the new WHO service delivery model of 2016. So in contact 1, we focus a lot on giving the mosquito net, and around that time is when we actually test everyone to make sure they don't have malaria in pregnancy. And then we speak to them to come back on the 13th week, in as much as it's not a formal contact. But because we know that we have to give IPTP at exactly 13 weeks, that is why you're seeing contact 1A. Then we encourage the mother to come on that day, because that is around the time we give them their first dose of IPTP with SP. And this one, even if we introduce the community IPTP, it has to happen at the facility, because all of us on this forum know that a person who is not trained may not be able to detect the 13 weeks of gestation. You need to assess properly and be very sure you're starting IPTP at 13 weeks of gestation. Then contact 2, that is at 20 weeks. That is where we're giving IPTP, and that is when you're giving your dose 2 of the IPTP. And contact 3, that is at 26 weeks, that is when you're giving your IPTP, and that is when you're giving your dose 3 of the IPTP. And contact 4 at 30 weeks is where you're giving IPTP, and that is dose 4 of the IPTP. And then contact 5, you're giving your 5th dose of IPTP. Contact 6, no SP if the last one of contact 5 was received, because then this is less than a month. You realize that this is less than a month, it's just 2 weeks. Then contact 7 at 38 weeks, then you're giving your 6th dose of IPTP. And at 40 weeks normally, because that's 2 weeks only, you're not going to be giving an IPTP. Please note that this applies to all mothers that are HIV negative and do not have other comorbidities like sickle cell disease. But we have alternative IPTPs that are not IPTP with SP. If you come across a mother who is HIV positive and they're not on cotrimoxazole for some reason, they're the ones that will come back to this other schedule on my left in green. But if a mother is living with HIV and they are on cotrimoxazole, we leave them to actually continue cotrimoxazole. If they had stopped taking cotrimoxazole for some reason that is not allergic to sulfur, maybe non-adherence, the moment they get pregnant, they should actually resume their cotrimoxazole, because cotrimoxazole also has an anti-malarial effect. And when a mother is on cotrimoxazole, they are also protected against malaria in pregnancy, them and their baby. And also the other thing is that we avoid giving both cotrimoxazole and sulfadoxine pyrimethamine, because they are both sulfurs and you're likely to cause toxicities if you give the both of them. So here the fact is that when a mother is living with HIV, we should start them on cotrimoxazole if they're not allergic to sulfurs, and or they should continue cotrimoxazole. And when you're reporting IPTP, these mothers should be reported as part of that IPTP because they are being protected. And how do you do it? Tag their cotrimoxazole onto the ANC visit. For example, a mother who comes in for first ANC, that will be their IPTP1. A mother coming in for their second ANC, that will be their IPTP2. A mother coming in for their third ANC, that will be their IPTP3. A mother coming in for their fourth contact, that will be their IPTP4. A mother coming in for contact 5, that is IPTP5. And then a mother coming in for contact 7, that is their IPTP6. And so you report it like that. Then for women with sickle cell disease, because the quality of care for sicklers has improved. Some of them are getting pregnant and they are coming into care. For them, we normally prefer that they are given chloroquine, that is 10 milligrams per kg weekly. But of course, you also have to routinely monitor their visual acuity, just to be very sure you're not causing retinal damage. But remember, in most cases, they're just going to be doing it probably for pregnancy, and maybe after that they can. The number of controversies around the use of SP vis-a-vis chloroquine in the sicklers, and a lot is still being documented for us to check to adjust chemo prevention among the sicklers. But fortunately for us, new molecules are coming on board, like dihydroartemisinin, piperaquine. But the debate is that now currently dihydroartemisinin, piperaquine is a second line. So if you take it for prophylaxis, what other alternative will you put in place for second line? These are things we shall, maybe if I'm given a chance, that I'll present and we discuss in the future, if I am ever given a chance, because you'll hear that as we take the DPs, that is dihydroartemisinin, piperaquine, into prophylaxis, because now chemo prevention is being introduced as a core intervention. We need to be going for other newer molecules that may actually even be having 3 drugs other than 2. But this is something we are going to discuss in the future. So this is how the IPTP and LLIN is done. Key thing here is that the moment you get in contact with the mother first time, give them their mosquito net, educate them on use, and subsequently you just follow up to see if they are using their mosquito net. And then you work together with the VHTs to integrate the check of mosquito net use during the time they do their quarterly home visits, just for them to be very sure the mothers are using the mosquito nets, because the use is what gives us results. So the treatment of malaria in pregnancy, please note that previously, as we were in school, we're being taught that treat every malaria in pregnancy as severe malaria. But you all acknowledge that there are cases of uncomplicated malaria in pregnancy. So we have uncomplicated malaria in pregnancy and we have severe malaria in pregnancy. It's very important that every other time you encounter a mother who is pregnant, be very sure that there are no danger signs, and that is how then you'll be very sure that whatever you're dealing with is uncomplicated malaria. Because remember, pregnant women are so prone to severe forms of malaria. So they're likely to come in as severe malaria in pregnancy. Key, as we shall see later, be in position to timely detect the danger signs, and the danger sign will point you to a complication that will be happening into this mother. Because clearly, if you're to define uncomplicated malaria in pregnancy, it's simply a mother who comes in with a history of fever, no danger signs, and positive RRDT or malaria parasites. But any mother who comes in with a history of fever, danger signs, as we shall see them later, because the danger sign is what points you to a complication. A danger sign that points you to a complication, either laboratory complication or clinical complication, and then as we are mentioning them here, and then a positive RRDT of malaria or malaria slide. So very important as we are managing, remember history taking is key, physical examination, but then also laboratory investigations. So we have an uncomplicated malaria. The recommended treatment, the recommended first-line treatment is artemether-lumefantrine. Previously, we were saying that this is for mothers in the second and third trimester, but the WHO position now is that you can actually use artemether-lumefantrine in the first trimester. As of last year, we are only pronouncing ourselves based on the experience from some of our senior colleagues and the expert opinion, and also the recommendation from the FDC of America, because for them, they concluded earlier. WHO was waiting for a bigger study, and then I think also a go ahead from their Malaria Policy Advisory Committee, and so that before they could recommend. But all of us know that, all of us who have used artemether-lumefantrine in the first trimester know that it is safe. And also the other ACT, that is dihydroartemisinin piperacin, is the other that is safe. We still have issues with understanding the safety of amodiaquine artesunate, and that's why you will see that it's not appearing in most of the NEP guidelines. But the few available literature handouts indicate that it could also be safe. But for now, we're saying ACTs are safe in the first trimester. So the second line is dihydroartemisinin piperacin, and the alternative second line is oral quinine. Remember, as you're managing uncomplicated malaria, that it comprises of both specific treatment and supportive treatment. The supportive treatment is basically aimed at relieving symptoms like fever, headache, joint pains, and the others. Then the management of severe malaria, normally the preferred first line and the recommended first line is IV or IM artesunate. If artesunate is not available, you can use IM artemether or IV quinine. But just in case you've used IV artesunate and you've given the 0-hour dose, 12-hour dose, and 24-hour dose, and then you sure it's being diluted and reconstituted the right way and being given according to schedule. And by after the 24-hour dose, you repeat the 24-hour dose of day one, and the assessment of the patient indicates that clinically they are not improving, but also their parastemia levels are not changing. Then you don't have to wait and continue giving IV artesunate. You're advised to quickly change to IV quinine, because currently we're beginning to document rising levels of resistance to ACTs to start with, but the culprit there so far that is being documented is the artemisinin arm of the ACT. Next door, Rwanda, they've already documented resistance to ACTs, especially the artemisinin arm of the ACT. And commonly, most of these resistance molecules come from the Mekong area, but this one is unique. It's not at all related to the ones of Mekong. So it could be specific to Rwanda. And even here in Uganda, we've already documented some in West Nile and Busia. So that is why, because we don't want to be losing any of our mothers, if you give on day one the 0-hour, 12-hour, and 24-hour dose, and you realize that because then after that you're supposed to continue 24-hourly. If you give on your day to your 24-hourly dose and you assess your patient clinically and you feel they're not getting better, even your repeat BS is not showing any changes in the parastemia levels, you're advised to not waste any time, and you have to just quickly shift to the IV quinine, given that background. But I'm not saying that we are yet declaring resistance, because there's a certain level at which you're supposed to declare that this is significant resistance levels and we should be changing to another molecule. We've not yet reached there. What we are actually documenting currently in Uganda is delayed parasite clearance. And but you don't want to have a delayed parasite clearance. And that is why we usually recommend that if you notice that a patient is not responding, quickly work out and think through, use your judgment and change to another alternative treatment. So These are some of the complications that you're supposed to identify and pick, because anytime a malaria patient has these complications, then that means that that patient now has severe malaria. And what points you to these complications are the danger signs which we all know in this forum. Patient refusing to eat at all, for patient vomiting everything, a very, very lethargic patient or a patient in prostration, a patient who has severe pallor, patient who has severe dehydration, a patient who has signs of shock. And kindly, for those of us who operate in the peri-urban areas, take note of the algae malaria. It's very, very common in pregnant women. What is algae malaria? It's simple. Any patient you see with severe malaria and they have symptoms of shock, suspect algae malaria, because algae malaria in most cases is a situation where you're having malaria coexisting with gram-negative bacteremia or septicemia. So normally when you get a patient who has malaria coming in with symptoms of shock, be highly suspicious. It's important that you also do blood culture for those kind of patients. So using those danger signs like respiratory, difficulty in breathing, fast breathing, and then also a number of other danger signs that we know very well. They will definitely be pointing you to some of these complications like respiratory distress. This is common, especially in children, but also it's very common in pregnant women, severe dehydration and shock. Following respiratory, the order is cerebral malaria, followed by respiratory distress, followed by severe anemia, followed by respiratory distress. Lately, renal failure is becoming very common, convulsions, hemoglobinuria. All of us have heard about the black water syndrome. Unfortunately, I may not get time to speak in detail to the way these manifest and the way we manage them, because these are about like 10 slides, because you have to talk to each of these. That is why I thought that maybe I'll be given a chance to just come in and speak to severe malaria management, including that for malaria in pregnancy.
Yes, you will.
Yeah, so hypoglycemia, acidosis, threatened abortion, and also incomplete and complete abortion, and name them. So the respiratory distress usually points us to severe anemia, but also there's this very big culprit, pulmonary edema, that is very, very common in our pregnant women. So it's important that we using the danger signs, we are able to identify this either clinically, because like here for hypoglycemia, in as much as you'll see the patient lethargic and weak and probably with convulsions, normally you have to do a random blood sugar. And if you get anything below 3.3 millimoles per liter or 60 grams per deciliter, then you're speaking to hypoglycemia. Then there are also controversies around the standard case definition for severe anemia in pregnancy. You remember for a very long time we've been speaking to less than 80 grams per deciliter, but no, for a very long time we're speaking to less than 7 grams per deciliter, but you wouldn't want to have a pregnant woman have anything less than 8 grams per deciliter. That is already severe anemia, and you need to be acting very quickly. That is it, and then I'll go and speak to the dosing schedule. Clearly here, what is important to us are the last two rows, because the first two are for children. How do we give artemether-lumefantrine? This is how we give. You will see that we give 3 tablets. I don't know if we have any mothers that lie in the category of 25 to 34 kilograms, because that would be really, really underweight. But you give 3 tablets in the starting. And please note the health workers on this forum. Whenever a mother tests positive, the ideal should be that you give them their first dose of the SCT in the clinic and instruct them to do their next dose 8 hours after. And then they can continue to do the 8 hourly for day 2 and day 3. It's very, very important. One, you're mitigating the likelihood of getting into severe malaria, because then you're beginning parasite clearance. Because remember, in our country here, the common culprit of the parasite is P. falciparum. This is a very notorious species of the Plasmodium. It is that is why it notoriously causes severe malaria. One, it multiplies very, very quickly. That is why we usually emphasize prompt treatment of any malaria case. It multiplies very quickly. It attacks all stages of red blood cells, whereas others prefer certain stages of red blood cells. This one attacks all stages of red blood cells. The other is that it causes the red blood cells to be sticky, and then they stick on the blood vessel walls and they occlude the blood flow and they cause hypoxemia. And so this is why we emphasize that when a mother comes in, they should get their dose in the facility and 8 hours, so that you have you build capacity for clearing the parastemia. And so this is the dosing for artemether-lumefantrine. All of us know how know the strength of artemether-lumefantrine, and I think the available doses on the market are very clear. So we do four tablets, start 8 hours after, then we continue 12 hourly for 3 days, and encourage the mother that if she completes the dose, or if along the while she's doing the dose, she's not getting any better, new symptoms develop, she has to come back to you for reassessment and probably change of treatment. Or if on completion of treatment, they are not getting better, they should come to you for reassessment. Then the preferred second line, that is a dihydroartemisinin piperacin. The brand names are quite a number. There's Pialaxin, there's duocortexin, there's Diatep. So we can focus a lot on 36 to 60 kilograms. Normally, the available preparation is 40 milligrams of dihydroartemisinin and 320 of piperacin. But we also have a prep of 80 milligrams and 640. So depending on what is available, this is the dosing schedule. And this is what we should follow as a second line. And this will be in a situation where someone has taken artemether-lumefantrine. They've done it correctly. They stored their medicines well. Health workers on this forum, please. Part of the things we should emphasize is storage of artemether-lumefantrine at home. If someone takes artemether-lumefantrine and they put it on a wall, on a window where the sun comes in, or they put it in a place where the insects or rodents bite the blister pack, and then the artemether-lumefantrine is very hygroscopic. It takes in the water. It becomes a placebo. It will not work on that mother. So try, as you're reassessing this person who has come in with treatment failure, try to understand, did they take the correct dose? Did they share their doses? Did they vomit some of the medication? And what did they do immediately after vomiting the medication? After you've assessed all that, when this patient who comes back, don't repeat an RDT, because the RDT will still be positive. There's that persistent antigenemia that is associated with the RDT use. Initially, we thought it stayed for about 14 days, but now some literature coming in shows that it can even stay for more than 21 days. So when you're reassessing a patient, never depend on RDT results, because they'll always be positive. So the best way for any patient you're reassessing, before you shift to second line, the best to use is microscopy. And it's very important that you ask your lab person to actually type the parasites, because the last malaria indicator survey indicated that we are beginning to get rising levels of other species. But fortunately, the ones they picked, I think, all respond well to ACTs, because they picked malaria, and actually in Busoga, it's one of the areas where they picked malaria. Vivax, that has a little of a unique way of managing, was not picked so much. But with the refugees coming in, especially from Southern Sudan, these are parasites that we may begin encountering, and actually we may even revise our treatment, because with Vivax, you need to actually add a primaquine on it for you to have effective treatment. Otherwise, the patient will keep coming back to you. So For severe malaria treatment, the components of effective severe malaria management include the following. Because remember, this patient has danger signs. So triage is very, very important. It is a life-saving measure. Because this is how you're going to pick danger signs, and after picking danger signs, do resuscitation, stabilize the patient before you do anything else. Triage your patient, categorize them. Are they an emergency patient? Are they a priority patient? Or they can wait? So the moment you feel that they are an emergency, what is this that is making them an emergency? Is it the respiratory distress? Manage that. Is it the severe anemia? Manage it. Is it the severe dehydration? Are they in shock? Manage it. Actually, this is a comprehensive presentation on severe malaria management. I can't do it together with malaria and pregnancy. I can only do it as a standalone because it's something that we need to really understand. Is our setup in our respective facilities supporting the saving of life of a patient who comes in with severe malaria, especially severe malaria and pregnancy? How is your triage station? Do you even have one at your OPD? Or if you have one, is it just put there for supervisors to see, or it's a functional one? If it's a functional one, is it according to the standard? Resuscitation. Ideally, every OPD should have a resuscitation room that is well equipped with the staff attached, because when you identify this patient, this is where they're supposed to go. And after you've stabilized them, now you can do a comprehensive assessment that includes clinical assessment, history taking and physical examination, then laboratory and radiologic assessment. One will wonder why I'm putting radiologic assessment. Radiologic assessment, if you're to diagnose pulmonary edema, you'll have to do a chest x-ray. But also for a mother who is pregnant, you have to do ultrasound, especially if the fetal movements are absent, or if the fetal heart is not according to what you want. Then after you've stabilized them and started them on care, which is either specific care and also the supportive care for the different complications you've identified, they should be monitored based on their scale of severe disease. They should be monitored. Then the key thing is that for lower level facilities, once you realize that you can't manage a patient, do prompt appropriate referral. This is very, very important. Then anytime you're managing a patient of malaria and pregnancy, whether it's uncomplicated or severe, there should be a clear follow-up plan and linkage back into antenatal care. So this is also another important component of management of not only severe malaria and pregnancy, but also management of malaria and pregnancy. Then don't forget that there can be comorbidities. It's important that we always look out for other causes of fever, because you'll treat your malaria very well, but the other causes of fever will not be catered for, and they may be the loss of the fetus or the loss of your mother. So it's important that we also do management, that is identify other causes of fever and appropriately manage them according to the Uganda clinical guidelines in order to save the life of this mother and her baby. So if you're speaking to the triad, this is how we sectioned it. We have the emergency category that has severe pervaginal, it has pervaginal bleeding, severe pallor, obstructed airway as may be seen in the noisy breathing, cold extremities, clammy skin, slow capillary return, and a low BP, current or ongoing episode of convulsions. This is different from when you're having a history of convulsions. That history of convulsions puts the patient in the priority list. Woman in labor, unconsciousness, cyanosis, features of severe respiratory distress, very slow skin pinch, sunken eyes. These last two are speaking severe dehydration. However, the priority patients will have edema involving both feet, mild to moderate respiratory distress, the referrals, patients in prostration, history of convulsions, a patient who is restless, someone who has a patient who has some dehydration, patient with trauma, burns or poisoning, temperature 39 degrees and above, altered levels of consciousness. There were debates around the temperature. Someone, actually in our teams, we debated, should we put this in the emergency category, altered levels of consciousness? Someone is not into really a coma, or they are usually here, the Glasgow coma scale above 9, you'd want, normally, okay, if you have any Glasgow coma scale above 9 to 10, normally these patients may be a little confused, disoriented in terms of person, place and time. They may be in the priority list, but they may not fall under the emergency: vomiting, all feeds, inability to feed. Then the women in this can wait in the line, but they are given priority. Then the others that don't fall on either side can wait in a normal queue and be seen according to the time they came in. Some of the laboratory tests we do under malaria include the RDT if a person has not had any medication before. And then also microscopy as a gold standard is what we recommend, but other tests include microscopy to quantify and classify type parasites. It's very important. You note that after your 0 hour, 12 hour, 24-hour dose, you may want to do a repeat BS, and then probably at 48 hours and 72 hours, just for you to be sure. Urinalysis to pick proteins in urine, especially for women who are convulsing. Complete blood cell count, or for HB, complete blood cell count, or HB estimation to diagnose and grade anemia, but also diagnose other comorbidities. Random blood sugar to make a diagnosis of hypoglycemia and gestational diabetes. Renal function test to diagnose acute renal failure. It's increasingly becoming common. So anytime you receive a patient with malaria, for as long as they have reduced urinary output, especially when they are not severely dehydrated, highly suspect acute kidney injury. Blood culture and CSF analysis, and then serum electrolytes. These are some of the key investigations we should do. Then, speaking to the specific treatment of severe malaria in pregnancy and generally severe malaria, there are 7 steps that must be followed. Key thing is we should weigh the patients to determine how many vials we're going to use, because then you know that the pack of the artesunate has a vial that contains the artesunate powder, artesonic acid powder. It has an ampule of sodium bicarbonate, and then that is for reconstitution. And then it has an ampule of sodium chloride, that is for dilution. So normally, when you weigh the patient, you will know how many of the vials you're going to use based on the patient's weight. After you have weighed the patient, this step 3, because then after that you determine the vials you're going to use. This step 3 is very, very crucial. It's highly contributing to the response of patients to treatment. Reconstitute the artesunate powder in the vial with the sodium bicarbonate. Normally, here it doesn't matter whether you're going to give IM or IV. You use, for example, if you're using the 60 milligram, using the 60 milligram vial, you have to put the entire 1 ml sodium bicarbonate the way it is. So why are we doing this? Why are we reconstituting? And normally after you've put the sodium bicarbonate, you should see a clear solution. It should be clear, not milky, not cloudy. Why are we doing this? Remember, I have said that what we have in here is artesunate acid. In the acidic or alkaline state, artesunate is very unstable. It will not be able to attach itself to the ring of the malaria parasite and destroy it and destroy the malaria parasite. So why we put the sodium bicarbonate is to stabilize the powder And the way you know stabilization has happened, or the way you know neutralization has happened, is by it turning out to be clear. And normally there are some other things they discourage us to do. One, once you put in the sodium bicarbonate, make sure that you rock the bottle gently. Don't shake it vigorously, because again, even after reconstitution, if there is some raise in the temperature in that environment within the bottle, it will again destabilize your mixture. After that, now you ask yourself, do I have a line in my patient? If it's going to be IV, then you're going to use the entire ampule of sodium chloride of 5 ml to dilute your reconstituted mixture. But if you're going to give it IM, then you're going to use less. You're going to use less of what you have as the sodium chloride. And normally here you will find yourself putting in that same vial, you'll be putting in 2 ml. So on this other side of IV, you'll have a total of 6 ml, and on the other side, you'll have a total of 3 ml. And then you go ahead to give the drug and draw your schedule. But it's very, very important, because remember, you as a doctor, you would have written in milligrams, but it's important for the person who is going to be able to give the injection to be able to calculate the mils required by a patient. And how do they calculate the mils required by a patient? For example, for the patients that are going to be given IV, for adults, I forgot to mention that dose. For adults who are above 20 kilograms, the dose is 2.4 milligrams per kg. And for those below 20, the dose is 3 milligrams per kg. Initially, it was 2.4 for everyone. But I think some literature came through, and they indicated that for patients who were less than 20 kilograms, there was slow response or non-response when you gave them the same dose of 2.4. So that's how we now changed them to 3.0, and so any patient who is less than 20 is given 3.0 milligrams per kg. Please note that artesunate initially was not recommended for use in the first trimester, that is until 2014, but later WHO, after getting literature that it was safe, it now recommended that artesunate can be used in all trimesters of pregnancy, even if somebody is 1 day pregnant, as long as you're sure they have severe malaria. So if you want to know the dose to give in meals, you'll get your dosing. Say, for example, if a patient who is above 20 kilograms, like in this case, they're showing us this patient is 26, you get 2.4 times 26. If they are going to get that dose they are going to receive that dose as IV, they will divide it by 10. But if it's going to be by IM, you divide it by 20, and then you'll get the mils. But whenever you get mils that have a decimal point, you round off to the nearest whole figure, even if it's less than 5, because there's evidence that actually underdosing, because you've rounded off downwards, will cause delayed parasite clearance, but you actually need very many milligrams for you to cause toxicity. So rounding off upwards is safer than rounding off downwards. So so that is how we dose, and then you get the meals you're supposed to give this patient. And the dosing schedule is that you give at 0 hour, assuming the patient comes in now like at this time of 9, then they are going to get their dose at 9, and then they will get their next dose at 9 a.m. in the morning and get again at 9 p.m. tomorrow. That is the dosing schedule. And then after that, if you feel they are not yet able to swallow or they are not clinically stable, you can continue your 24-hourly dose to a tune of about 6 days to make a total of 7 days. But even then, when you complete, it's important that 8 hours after, regardless of whether you've done for 2 days or 7 days, you give a full course of an ACT. For all severe malaria patients, the recommendation is that continuation treatment is not AL. For as long as you're treating severe malaria, the continuation treatment is not AL. The continuation treatment is dihydroartemisinin, piperaquine. That is in one of our new guidelines from last year. You give 8 hours after, and then you give daily until the 3 doses are over. But when the patient is better, the follow-up plan should be that when they come back a month later, as they're doing their follow-up, you give them another dose of DP, and then after that, I think they can continue their SP. I hope all of us are getting that, because it's a new guideline. So the follow-up is usual as follows. It should include the general follow-up in case of new or persistent symptoms. Mother is encouraged to return immediately. And please note that you need to align your your follow-up plan to the ANC contacts somehow. Please note the trimester of the mother and then schedule your plan. But clearly, remember, regardless of whether it's first trimester or third trimester, there is the general follow-up plan for severe malaria patients. Ideally, all severe malaria patients should be seen on day 7. And then they're supposed to be seen again on day 14 and then 28. Then after that, that is at 28 days is where you give them their dose of DP. And then you start reviewing them monthly for the next 6 months. But now here for the mothers, you take them back to the ANC and they are followed up during ANC, and the ANC people will decide on whether on how to review the mother, whether they should strictly follow the contacts or they need to put in their contacts because the mother is not well. And so this can be guided with the different trimesters with which you're acting, and then that will also, and for each there are usually actions that you're taking. But key to remember here, as you're discharging this mother, they should, if they didn't have a mosquito net, even if they had, all severe malaria patients are supposed to be discharged with a mosquito net. This is very, very crucial. And they should be encouraged and they should be attached to their VHT. Health facilities should have a list of the VHTs of the respective villages in their catchment area. This is what we expect. So that when you're sending back this patient, you contact the VHT and encourage her to follow up this person and encourage them to use the mosquito net and even encourage them to return for their follow-up visits. This is one of the things we're emphasizing as we struggle to reduce the malaria mortality by 75% of the 2019 levels come 2025. So nationally, this is how we are performing for intermittent preventive treatment 1, 2, and 3. 1, it means a mother has at least had a dose of IPTP. 2 means that a mother has at least had 2 doses. 3 means that the mother has had at least 3 doses. What gives us impact is a minimum of 3 doses or more. So kindly note how we've been performing over the years in starting 2020, 2021 to date. You note that our IPTP1 is also suboptimal. IPTP2 is suboptimal. IPTP3, we came a long way. You check where we came from, what, 17% at some point, but we're striving to get there. But all the same, this is suboptimal. We need to take note of this. So these are the different regions. You can look out for Busoga, for IPTP1. I don't know if you're happy with this picture. This is last quarter, you were at 676. For the 2 doses, you were at 67. And for the 3 doses, you were at 46. According to our set targets, you fall in yellow, but we would have wanted you to be in green. But please note that we are still operating at suboptimal levels. Now, when you come to district, this is how we are performing. Very few districts are operating above 70%. And here, I'm not seeing any, apart from, I don't know which district this one is, but it's not even still in Busoga. Busoga, I note that most of your districts are between 41 to less than 60%. They are in yellow. So look at Kaliro. Kaliro is red. Look at Buyende, look at Kamuli, look at Luka, Iganga, Jinja, Bujiri, Bugweri. You note that Mayuge, Namayingo, we are in yellow. How do we get into lighter green and dark green? This is how we are performing in terms of IPTP3, at least because this is what gives us impact. So we are closely monitoring it. So we're going to see then when it comes to mosquito nets, you note that only this amount of women as of February 2022 were receiving nets. And then when it comes per region, Busoga, you're almost there. 79% of your women are receiving nets, but you can work to the level of Lango and Chigezi and Nkole. Then when it comes to malaria cases, don't you realize that we contributed highest, I think? You're seeing Busoga. We reported the highest malaria and pregnancy cases. Am I right? Yes, I am right. Yes, we appreciate the prevalence we have in Busoga, but you note that West Nile, Teso, Lango, Karamoja, Busoga, Bukedi, and Acholi are still a challenge. And I think Busoga, so far, we are the highest.
Yeah, the highest.
We need to do something.
On the walls.
So malaria in pregnancy, still Busoga, we have the highest admissions. And then we also have we are actually having 1.3 as deaths, followed by, I think, North Central. North Central, we are doing something because their levels are not actually that high, but we're wondering why they're getting a lot of deaths. At least for Busoga, we know that you're seeing the number of women that died due to severe malaria, due to malaria in pregnancy in Busoga as of that half of 2022. We need to do something. These are some of the challenges we are encountering. The demand of and utilization of antenatal care services is suboptimal. As we speak, ANC1 attendance in the first trimester at country level is 32.8. It's unfortunate I'm not able to share regional, but I have it. I would see where Busoga lies, while the proportion of pregnant women that attend at least 4 times is 50%. So currently for IPTP delivery and mosquito net delivery, we are entirely dependent on this platform. If it's operating at these levels, we shall definitely remain low. Number 2 challenge is programming and planning for malaria, including malaria in pregnancy at some national levels is not well done. You find that we plan so well at the national level, but at subnational level, people have totally different goals, people have totally different priorities, they have different targets. And then also this is made worse by the inadequate coordination and collaboration of and between actors at the subnational level. Ideally, we're supposed to rely a lot on the malaria focal person and ADH or maternal child health. But are these two speaking to each other? Are they planning together? Do they know their responsibilities for malaria in pregnancy? Then the imbalances in stock of malaria and pregnancy preventive commodities, that is SP and the mosquito nets. Previously, were challenged by stockouts, but we've managed that. We are currently standing at a tune of about I think 26% facilities with stockouts. more than 4 months. But stockouts are no longer a story, because then we also have overstocks. So it's basically stock imbalances, and all we need, we are going to put across some recommendations. Then the gaps in knowledge about the updated malaria and pregnancy guidelines by the frontline service providers. And then the missed opportunities, but also the gaps in knowledge of the new antenatal care model guidelines. Then the missed opportunities to document the mothers living with HIV that are on cotrimoxazole, yet they are also protected. Then the attitude by the community and health workers towards malaria and malaria in pregnancy is poor. Prevention for malaria is never prioritized. Somehow malaria is taken as a simple disease, but it is going to get very problematic, because actually right now as we speak, it has changed its funds from the poor people, because now you see they are moving around with asymptomatic malaria and waiting for you whenever you go to the community, you who has never suffered malaria and are very vulnerable, to transmit to you whenever the mosquito bites them and it bites you. So the funds are now changing to the well-to-do whenever they get into those communities. So at some point, malaria will cease to kill. Okay, the poor people will live with the malaria parasites, but the well-to-dos will die of malaria whenever they get exposed. Because that's how the picture is changing, and even the vulnerability is changing a little. So this business of malaria is a simple disease, and we shouldn't worry about it. I think we need to think through, because I think that is not the case. So we recommend the following. We need to strengthen community engagement. We need to come up with data-driven messages, things that can make people understand the gravity of malaria and the importance of preventing and reducing the malaria burden. We need, one of the things we are planning to do is to introduce the community intermittent treatment of malaria in pregnancy, as we try to strengthen the platform of delivery, that is the antenatal care. Now we need to also do pregnancy mapping. That is, we should build the capacity of our VHTs, because these VHTs actually have registers where they register their households under their care. And in there, they register everyone, including the pregnancy status of the women of childbearing age in that household. So ideally, it's a matter of encouraging them to try and identify those who are pregnant and refer them to the facility, and even follow up to make sure they've attended ANC, and follow up on which actions were given to the mother, and encourage them to return for their subsequent visits. Then also community sensitization on the importance of early ANC attendance and retention into ANC care. These are some of the things we need to do as one way of strengthening community engagement and involvement. Then we need to promote the practices that lead to high index of suspicion for pregnancy within all health workers. Some of you who have been working for some time, remember that when we wanted to increase the uptake of family planning services, we made sure that every point of care somehow delivered some service around family planning, either counseling or identifying mothers who want to start family planning and linking them into care. So we want to borrow this kind of approach, whereby every health worker, whenever you're talking to a woman of childbearing age, ascertain their pregnancy status, where possible, test them, and immediately link them to the antenatal care. But then also, while in the antenatal care, we need to borrow the approach of HIV. How do we schedule these mothers to return? How do we document when they are supposed to return, and follow up whenever they have not returned, to make sure that they come for their services? For as long as we do this and the commodities are available, I am very sure IPTP will improve. I am very sure we shall not have those high cases of malaria in pregnancy, we shall not have those severe cases, and we shall not have those deaths due to malaria in pregnancy. Then we also need to get the districts and all stakeholders to routinely monitor stock of the commodities and timely respond by supporting redistribution of these commodities so that we have balanced commodity availability. Then we need to scale up the dissemination and reinforce the use of malaria in pregnancy updated guidelines among service providers, including those in the private sector. You saw the red in Kampala. They have the nets, they have SP, they don't have actually SP stockouts, but why are they having that IPTP coverage at that level? It's simple. They are not adhering to guidelines. We are mostly dependent on private sector in Kampala, and they are not aware of these guidelines. So we need to make them aware of the guidelines and encourage them to use the guidelines. They encourage all health workers to capture and report information for mothers on co-trimesters as part of IPTP. Then finally, we need to expedite the rollout and adaptation of the new WHO ANC guidelines. And this brings me to the end. Thank you. But just to take you through, I would have wanted to actually get you to see this as just in case, but also I know you can't take in all, but for severe malaria management in pregnancy, we normally have, we also have this. I can just show you briefly because I have it here. Clearly, I didn't speak to referral, but this is the slide on referral. We shall talk about it when I next have a chance. Then also the management of mothers who may have fevers due to other causes that is not malaria. We also have elaborate slides on how to manage each of the complications of severe malaria. These are the slides, but this can be discussed another day. Thank you so much. Over to you, moderator.